Okay, and welcome to the Davies Use Case webinar being presented by Unity Healthcare on depression screening. This is a Davies Award-winning use case for value of health IT. And I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to their value. The Davies Award-winning use case have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It's my pleasure to welcome our speakers today, Angela Job and Angela Hinkle. Angela is the Vice President of Systems at Unity Healthcare, which is providing medical homes to over 105,000 residents in Washington, D.C. Adoption and expansion of health information technology throughout Unity's more than 25 sites. Under her leadership, Unity earned the Health Information Systems Society HIMSS Davies Award in 2012, and now in 2017. Dr. Job is an active member of the District of Columbia Health Information Exchange Policy Board. Over the past 10 years, Dr. Job has worked to realize for both Unity and its patients the transformative power of health of information technology to engage and improve the health of the community. Marcia Hinkle has been the Assistant Director of Social Services, Behavioral Health since May 2013, and she leads behavioral health integration at Unity. She's the clinical supervisor for the licensed mental health clinician and does clinical work 2 days a week at the Minnesota Health Center. She provides behavioral health services training for the social services department as well as to health center teams and providers. She co-chairs the DC PCA BHI peer group and is an active member of DC Behavioral Health Association. From 2002 to 2013, Marcia worked at Anchor Mental Health, a DC core service agency and part of Catholic Charities DC. She managed the day treatment and supported employment program, then was promoted to the clinical manager for intake, counseling, and training. She recruited, supervised, master's, and doctoral level interns for those programs. While at Anchor, Marcia chaired the Trauma-Informed Care Task Force, served on the Project Peer Grant from the Department of Justice, was a mentor for the Addiction Technology Transition Commission, East Coast Leadership Initiative, and the Washington, D.C. Co-occurrent Disorder Leadership Team, both SAMHSA grant projects. She has maintained a practice since 1991 and became a certified clinical supervisor for LP candidates in Maryland in 2011. So I will turn the presentation over to you all.
This is Angela, and we're very excited to share with you the work we've done on depression screening and using health in doing that. Today, I'm going to give you an overview of Unity Healthcare, who we are and what we do, and then I want to talk a little bit about change management and how that has impacted the work that we have done in this particular case study. And then I'm going to turn it over to Marcia, and she's going to take us through the details of the depression screening case study. And no HIMSS Davies Award is won on its own or with a few people. It's always an organizational effort to really get it done. So there were many, many people who actually demonstrate the power of technology and demonstrate how it can impact care through their actions. But we do have a Davies team, and this is our team. Catherine Anderton, myself, Marcia Hinkle, and Cherie Jones, as well as Dr. Andy Roby are part of our application team. We are a federally qualified health center in the District of Columbia. We serve over 100,000 patients a year in 500,000 visits. And our mission is promoting healthier communities through compassion and comprehensive health and human services, regardless of the ability to pay. And that is Michelle Obama there in the picture. So that's one of the benefits of being in the nation's capital. Often we get a chance to visit with some of the political time. We have sites throughout the District of Columbia, many of which are health centers. We have many of our sites are inside of homeless shelters. We have a couple of school-based health centers. We have a significant homeless outreach program that includes foot outreach to homeless as well as a mobile van. And then we do provide health services in a couple of the DC jails. Our services include primary and specialty care, behavioral health care, which is integrated with our primary care, dental care, and then we do serve a number of special populations of people, including persons experiencing homelessness, people living with HIV, citizens returning after incarceration, and Title X, our Women's Health Program. We are patient-centered medical home NCQA recognized, level 3 recognized organization. And I just wanted to touch a little bit on what our technology platform is. That's sort of undergirding everything we're doing. We have a highly customized integrated practice management and EMR system that we have had since 2009. And on top of that, we have a number of accessories to that, such as the patient portal, dental application, and a number of other things like that. This technology is being used by over 260 providers, and nearly all of Unity's 1,000 staff members use some form of this technology throughout their day, and it is supported by about 6 application analysts as well as about 3 data analysts. And I spent a little bit of time talking about our change management because it is another sort of pillar of the work that Marcia is going to talk about, and has really led to a lot of the success we've had in terms of changing and modifying the HR so that our clinical staff can use it to do the work they need to do. We have a very robust system of change management that helps us to develop and adopt well-thought-out changes in an organized manner. There's 3 major pillars. We do have a strong governance structure, and then the organization has supported training as a big part of it, and invested in training of staff, as well as we have a very strong system of support for the technology. With respect to governance, there's a number of teams, very busy, that helped to keep the EHR in running the way that we want it to run. The major teams that were took our case study are our EHR stakeholders, which is our group of leaders can basically bring the resources to bear to make the change. We have an implementation team that actually does the changing of the technology itself and is part of communicating the change throughout the organization. We have our configuration team here down at the bottom that change the external look of the EHR or the application look, how an end user sees the EHR. And then we also have the reports team that works with this so that once we have the data going in, we can always get it out. Or not always, but we try to get it out. And then we've developed a basic approach, which is to start by developing workflows. When we first started on this journey, we didn't do it that way, but we found that starting with the workflows first really makes the best, allows us to adopt the best change, and then modify the EHR and then train staff. And we can change that last. A little bit more. Our technology group, the HIT group, and the reports team works closely with the QI department, and in most cases, the QI department is broken down into various working groups that might be working on particular projects or changes, and then a configuration team to develop the workflow. Really disseminating the change. Once that we agree upon the workflow and the change and get it into the EMR, the working groups will also, in addition, develop the training that needs to be rolled out throughout the organization. We have had a lot of success with developing multidisciplinary team-based training and have been using that as a way of conducting our training as of late. Lastly, we try to plan up front. We've learned to plan reinforcement of training, that it's not just enough to train once. We have to figure out how we can either get layered training or layered rollout and subsequent reinforcement to make sure that we're getting the change we're expecting. We'll turn it over to Marcia, and she is going to take us through the details of our depression screening case study.
Healthcare serves patients who live in sometimes dire circumstances. Certainly in poverty, they may lack insurance, and they're in underserved urban and rural areas. These circumstances are correlated with a higher rate of mental health problems, especially depression and anxiety. And so it became an important priority to bring screening for these problems into our primary care setting. The Behavioral Health Project, depression screening was conducted for the most part by 7 of our mental health clinicians, as well as primary care providers who might be responding to a patient report of depression or noticing some depression. But there was no standardized way to assess symptoms and severity, and it was very much a hit or miss process. So we knew that there was a significant number of undiagnosed and untreated depression among our patients. Our goal is to screen consistently with a standard and validated form to track what percentage of patients were screened, whether follow-up was documented by those who had screened positive. Although some screening had taken place in 2014 and earlier, it was limited due to the relatively small number of mental health clinicians for our more than 100,000 patients. And the results were not documented in a way that could be collected and analyzed. They would have had to have been counted manually. consists of two parts. The PHQ, or Patient Health Questionnaire 2, asks about frequency of sad or depressed mood and anhedonia, or lack of interest in activities that used to be pleasurable during the past 2 weeks. If a response to either of the questions was yes, then the PHQ-9 would open automatically. These prompts, along with the follow-up, were easily located in the HPI Adult Behavioral Health folder. The screen, once opened, then takes the MA or the nurse through a series of questions that identify the essential symptoms of depression. Patient paper copy of the form to complete while waiting to see the provider, and then the MA would transfer those responses into the smart form in the electronic health record. Or they might ask the questions directly from the computer screen and put the answers in as they were received from the patient. In either case, scoring was done automatically, and along with scoring, the form suggests a diagnosis. About depression with the usual intake questions of chief complaints, what over-the-counter medications are you taking, getting vitals from the patient like blood pressure and temperature. We open the door for patients to talk about mental health concerns in the primary care visit, and hopefully lowered stigma on this particular problem or concern in patients' lives. We were no longer saying you can only address this if you go to see a specialist, but no, we can talk about this in your primary care visit. A significant factor in effectively rolling out this new process, and also then being able to collect the data and look at what was happening site by site, provider by provider, or even patient by patient. The PHQ-2 and 9 Smart forms were purchased from our EHR vendor for depression screening, and so we were able to get off of paper copies that had to be scanned into the chart and have the score automatically integrated into the progress note for that visit. The multidisciplinary team developed and configured the HPI to include the Smart Form assessment, and then also to have guidance for the follow-up plan, and also to touch on substance abuse documentation. In the prevention section of the progress note, a behavioral health section was added to document that follow-up. We'll look at that a little more closely. Our MAs work off of a flow sheet for intake, and so we added the depression screening and alcohol and drug questions to that flow so that they could see if the patient was due for that screening along with any other annual or semi-annual tasks like immunization, lab work, etc. For symptoms of depression. So for the provider, the follow-up was written to have a better understanding of the impact of these symptoms in the patient's daily life, the severity and frequency of the symptoms, the history of problems, and also treatment. It also included a prompt to consider the interaction between any medical illness and the current episode of depression. And we know that certain medications and certain conditions are more likely to have depression as a co-occurring problem. One providers were quite nervous about was suicide ideation or suicidality and how to respond to that. So we built in a fairly standard set of questions to assess risk so that patient and provider both would have a better understanding of what was going on if the patient responded that yes, they'd had some thoughts of hurting themselves or ending their lives. It allows a possibility then for the provider to take the next steps appropriate to the level of risk, including the type of referral or the urgency of the referral. The PHQ-9 itself also prompts the provider to follow up on the suicidality question if the response was positive. We add to our order set, trying to do our best to bring all kinds of resources into the provider's hands in the course of the visit. This included guidance on prescribing, multiple versions of patient handouts for various mental health problems like stress, depression, anxiety, and in several languages. There were fact sheets as well if a child was being diagnosed on how to deal with that as a parent. And, of course, referrals for patients of all ages and levels of need to both internal and external resources. The provider also configured for documentation that a follow-up plan was discussed with the patient. Along with a date for the follow-up plan, the patient's encouraged to commit to one or more common activities that are known to reduce symptoms of depression, such as increased exercise, reaching out to social support, getting adequate sleep, etc. Referrals to case managers for concrete need assistance, psychiatry, and/or therapy were also included in the actions they could take. And this formed a sort of immediate and very direct care plan for the provider and the patient to agree to. Now, getting this rolled out with all of the staff and taking it beyond the comfort level of a mental health clinician or a psychiatrist and into the realm of primary care was a challenge. We spent about 3 months in the fall of 2014 doing individual site visits and going to the provider staff meeting in order to talk with them about their concerns about what would happen as they were asked to screen for depression. The providers were primarily worried about 2 things. One was that there weren't enough resources to refer to in the district, and they were unclear on how to prescribe and felt that the lack of psychiatric support was a critical factor. So both of those issues were addressed at length in our training for rollout, which was in January 2015, and also in a follow-up training in March. We are on educating our patients and helping them understand that this was a part of their visit to the primary care provider. We developed a series of 6 posters in both Spanish and English that just connected the idea that you could talk about your feelings as well as your aches and pains, and that checking your stress level was just like checking your blood pressure, and inviting them to talk to providers about how they feel. We knew that this would also have a positive secondary effect on all of our staff, not just providers, but our registration clerks, our nurses, as they got more comfortable with addressing this in the primary care visit. When we arrived from launching this project, we have to start just by looking at the change in how many patients were screened and had follow-up services provided. Again, we assumed pretty much a 0 point prior to launching the project in 2015 because the screening had been so intermittent and couldn't be accurately counted. By the end of 2016, 44% of our patients who came through the door at least once had been screened. And in 2016, that was 30,000 patients plus who had a depression screening and follow-up needed. And that number is steadily climbing. One of the challenges that we have is the idea that staff have that the screening should only be done once a year, as so many protocols are tied to a 12-month or a 6-month interval. The patient might come in February, but their last screening was done in November. So the MA wouldn't do it that time. But then perhaps the patient doesn't return that year, and so we have a 0 screening for that patient in that 12-month window. The problem we're addressing with education, encouraging everyone to be screened at their first visit in that calendar year. Investment with this project has certainly been a change in the coordination of care between our mental health clinicians and our primary care providers, a much more collaborative and active partnership in providing care to patients who are being seen for both services at our health center. Staff connecting patients to resources and support. Patients with mild to moderate depression are identified and treated in primary care and have been responding positively without a need to refer to scarcer resources like our psychiatric care specialists. This is the patient and the provider to discuss other mental health concerns. So while the patient may not screen significantly for depression, that conversation allows them to talk about the fact that their sleep is disrupted by anxiety and they can't stop worrying. And so it opened the door in a comfortable way for problems to be addressed. We even have identified patients who have more significant mental illness and have helped to connect them to appropriate care because they know they can talk about it when they come in. So, of course, improves the patient's ability to adhere to treatment protocols for somatic problems. They're more likely to take better care of themselves in terms of diabetes or hypertension, adjusting their diet or exercise when they are not suffering from depression. And so we hope to see over time a correlation between that treatment and somatic health outcomes. Certainly increased identification of depression symptoms and the need for treatment. And it gave the providers a sturdy platform and raised their confidence in addressing mental health and substance use issues. We know our hypertension project, which is described in a separate webinar, training and retraining is key to consistently meeting goals. So in addition to 2 all-staff, all-site trainings that were done by webinar, there were follow-up visits made to individual sites to check on how they were doing, sitting in on provider meetings to ask about problems and barriers, continued retraining for our MAs, who are the starting point for this process. Data relationship between medical provider and mental health clinicians because it gives them a common language. As the therapist, I can say to my primary care provider, oh, this patient that we share scored 23 when she was first referred to therapy on the PHQ-9, and now her score is only 14. The medication and therapy seem to be working well. It gives us and improved coordination of care. Attention to this project, and we hope if you have any questions, you'll feel free to contact us through our website.
Arno, we'll turn it back over to you.
Okay, thank you so much, Marcia and Angela, for that great presentation. Both presentations you did today were really very good, and I just want to remind viewers where to go find other Davies use case webinars and information that could be found on the Davies Award website at HIMSS.org /Davies. Again, HIMSS.org /Davies. There's information on how to apply for Davies Award and other valuable use cases from other organizations. And again, thank you, and